robotic surgery or TORS, but I don't have a experience using a TORS or robots. But I think the next speaker will discuss about TORS in management of the parapharyngeal space tumor. The complication of the surgery in the PPS can be neurovascular injury, hemandibulotomy complication if we perform hemandibulotomy. It's a tumor recurrence, and other complications such as burst bite syndrome. Burst bite syndrome is manifest recurrent or severe pain in the parotid region in the initial oral intake. I'll conclude my presentation that the anatomic relation of the PPS are complex. Accurate imaging of the parapharyngeal space is essential to planning surgical resection. A treatment of the patient with a tumor of the parapharyngeal space remain challenging. Surgery in the parapharyngeal space can be done safely with good tumor exposure. Surgical approach is depending on the location of the tumor and also the surgeon preference. Thank you very much for your time. Have a great day. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Dr. Sukri. It's very nice and informative lectures. And you also mentioned, and you also mentioned a little bit about transoral surgery. And it will be great because it's related to our next topic. Our next speaker, Dr. Alok Takar, will be presented about the transoral robotic surgery for parapharyngeal tumor also. And Dr. Alok Takar is served as professor and chairman of the Department of Otolaryngology and Head and Neck Surgery at the All India Institute of Medical Sciences, New Delhi. And he has additional responsibility for head and neck cancer services at the National Cancer Institute affiliated to the IIMS New Delhi. And the focus of his work has been head and neck oncology and skull-based surgery. And of course, he has many experiences about transoral and laser surgery and robotic surgery also. And with that,
On the location
I
of the
ask
tumor
that you
and
give your full
also the
attention
surgeon
to
preference.
Dr. Alok Takar and help in
Thank you very
welcoming him
much
to
for
the
your
room.
time.
Dr. Alok
Have
Takar,
a great day.
the
Assalamualaikum
time is yours.
warahmatullahi wabarakatuh.
You also have a recording or you will give
Thank you very much,
presentation?
Dr. Sukri.
Dr.
It's very nice and informative lectures.
Okay,
And you
very
also
nice.
mentioned,
Thank you very much. Please,
okay,
you can start
and
to
you
share
also
your
mentioned a little bit about transoral surgery.
for
And
having me visit this
it will be
meeting,
great
even though
because
it's virtual.
it's related to
I did see
our
Dr. Adham
next
on
topic.
the list of people who were around, so I hope she's still
Our
around. And
next
thank you,
speaker,
Dr. Adham, for
Dr.
inviting
Alok
me.
Takar, will be
May I please share
presented
my
about
screen?
the transoral robotic surgery for parapharyngeal tumor also. And Dr. Alok Takar is served as professor and chairman of the Department of Otolaryngology and Head and Neck Surgery at the All India Institute of Medical Sciences, New Delhi. And he has additional responsibility for head and neck cancer services at the National Cancer Institute affiliated to the IIMS New Delhi. And the focus of his work has been head and neck oncology and skull-based surgery. And of course, he has many experiences about transoral and laser surgery and robotic surgery also. And with that,
On the location
I
of the
ask
tumor
that you
and
give your
also
full
the
attention
surgeon
to
preference.
Dr. Alok Takar and help in
Thank you very
welcoming him
much
to
for
the
your
room.
time.
Dr. Alok
Have a
Takar,
great
do you
day.
see my screen?
Assalamualaikum
Time is yours.
warahmatullahi wabarakatuh.
And do you hear me?
You also have a recording or clearly you will give
Thank you very much, Dr. Sukri.
So
That's
yes,
very
this
nice
is
and
about
informative
transoral
lectures.
and
Okay, and you
very
also
nice
mentioned,
both
thank you very much.
Singh and Dr. Rahman have
Please, you can
spoken on
start and you also mentioned a little bit
Thank you,
about
Dr. Adham, and
transoral surgery.
follow for having me, Dr.
It will be great because it's related to our next topic. Our next speaker, Dr. Alok Takar, will be presented about the transoral robotic surgery for parapharyngeal tumor also. And Dr. Alok Takar served as professor and chairman of the Department of Otolaryngology and Head and Neck Surgery at the All India Institute of Medical Sciences, New Delhi. And he has additional responsibility for head and neck cancer services at the National Cancer Institute affiliated to the IIMS New Delhi. And the focus of his work has been head and neck oncology and skull-based surgery. And of course, he has many experiences about transoral and laser surgery and robotic surgery also.
On the medial side,
and with that,
On the location
I
of the
ask that
tumor,
you give your full attention to Dr. Alok Takar and help in
Thank you very much for your time.
Dr. Alok
Have a
Takar.
great day.
And she's yours.
and do you hear me?
You also have a recording on. Thank you very much, Dr. Supri. That's very nice and informative lectures. Okay, and you are nice. Thank you very much. Okay, and you also mentioned a little bit about transoral surgery. This will be great because it's related to our next topic. Our next speaker, Dr. Alok Takar, will be presented about the transoral robotic surgery for parapharyngeal tumor also. And Dr. Alok Takar served as professor and chairman of the Department of Otolaryngology and Head and Neck Surgery at the All India Institute of Medical Sciences, New Delhi. And he has additional responsibility for head and neck cancer services at the National Cancer Institute affiliated to the IIMS New Delhi. And the focus of his work has been head and neck oncology and skull-based surgery. And of course, he has many experiences about transoral and laser surgery and robotic surgery also. And with that,
On the location
I
of the
ask
tumor,
that you give your full attention to Dr. Alok Takar and help in.
Thank you very much for your time.
Dr. Alok Takar.
Have a great day.
And she's yours.
And do you hear me?
We also have a recording on. Thank you very much, Dr. Supri. That's very nice and informative lectures. Okay, and you are nice. Thank you very much. Okay, and you also mentioned a little bit about transoral surgery. This will be great because it's related to our next topic. Our next speaker, Dr. Alok Takar, will be presented about transoral robotic surgery for parapharyngeal tumor also. And Dr. Alok Takar served as professor and chairman of the Department of Otolaryngology and Head and Neck Surgery at the All India Institute of Medical Sciences, New Delhi. And he has additional responsibility for head and neck cancer services at the National Cancer Institute affiliated to the IIMS New Delhi. And the focus of his work has been head and neck oncology and skull-based surgery. And of course, he has many experiences about transoral and laser surgery and robotic surgery also. And with that,
On the location
I
of the
ask that
tumor,
you give your full attention to Dr. Alok Takar and help in.
Thank you very much for your time.
Dr. Alok Takar.
Have a great day.
And she's yours.
And do you hear me?
We also have a recording on. Thank you very much, Dr. Supri. That's very nice and informative lectures. Okay, and you are nice. Thank you very much. Okay, and you also mentioned a little bit about transoral surgery. This will be great because it's related to our next topic. Our next speaker, Dr. Alok Takar, will be presented about transoral robotic surgery for parapharyngeal tumor also. And Dr. Alok Takar served as professor and chairman of the Department of Otolaryngology
responsibility for hepatic cancer services by International Cancer Institute affiliated to IIEMS New Delhi. And the focus of his work has been head and neck oncology and scalp surgery. And of course, we have many experiences about transoral and plastic surgery and robotic surgery also.
On the medial side,
And with that,
lateral side,
I ask that you give us and help in
Thank you very much for your
very last, and do you hear me?
we also have like thank you very much. Okay, thank you very much.
Dr. Alok,
You also mentioned a little bit about transoral surgery. It's really great because it's related to our next
So where did I end up missing you?
speaker.
You have seen me play a part of my presentation.
slide number
Robotic surgery for parapharyngeal
Institution that I work in, the
Dr. Alok Takar served as President and Chairman of the Department of Laryngology and Head and Neck Surgery at
Yes.
India
So
Institute.
this basically lists the situations where you have to be careful before we get involved with
Additional responsibility for head and neck cancer services by International Cancer Institute affiliated to
But now with improvement in radiology, you can actually access or you can actually assess every situation with regard to the comprehensive and now to be very clear the transoral robotic surgery, the medial surgeons and the
with that
lateral side. So what transoral surgery allows us to, of course, is to work with miniaturized instruments.
Thank you.
Size the mouth, somewhat remote and with these instruments you can actually look inside the scope and the not everything is done by the robotic surgeon. There is another surgeon out there. This is how we tend to work. The robot is basically used by the surgeon for access areas of elimination and for so many other things. So this is what the robot allows you to do. It is basically used by the section and what you see here is a patient who's having an oncological operation for the base tumor. So this basically is the advantage of the robot. But we can here just illustrate what we can do with the robot, and the robot allows you to have localized by the hand. It allows you to have a now with the continuously you can access the mouse and it's almost like you're sitting inside the mouse and it's a operation and everything, all your movements are transmitted to the body arms. Now there are 7 degrees of freedom which is on the surgery. They get forward and back like one transoral surgery allows you to, of course, to work and what it also does is that it takes away your tremor, especially in terms of you work in a miniaturized fashion. There is scale mode. You move hand millimeters to robot at 1 millimeter. So you have very good fine robot. And so when you apply this to the now that this has become available for you, you can use it for undertaking transoral resections with parapharyngeal space tumors. So as we said, there are many reasons not to get involved with the parapharyngeal space tumors. These are tumors very clearly ideal. Now we still have a 5-year location which is favorable. No one can be part of the parapharyngeal space. The ICAS is that the guys also and as we said, we have checked the information about how to use it. So well marketed, it's not possible. This is obviously a trauma in oncology. specific adenoma in the parapharyngeal space. Again, pre-styloid, you see the styloid process there, and this is pre-styloid. You see the parotid is free. You see the vessels are pushed laterally, and again, an ideal situation for a transoral excision. So if you do these patients transorally and you do it with the Norbert, it's a fairly safe way of moving forward. I'll just show you a small clip. So this lady was much older. She's 63-year-old. She has a right-sided. So how do you approach it? You approach it by taking an incision, lateral overvision back to the anterior condylar pillar, and then you go down there, you expect that this tumor has expanded also, and then you would encounter the superior constrictor muscle, and release the collagen from that here to get to micrographic. And so thinned out, you hardly see it. Here there's little fibers here, as you go up, you might see a little bit more fibers. And so you should take a mucosal incision. And so when you apply this to the now that this has become available for you, you can use it for undertaking transoral dissections with parapharyngeal space tumors. You can see you work in that space, and here's the you come laterally. You can see the ICL laterally pulsating there. And we use these stamp grafts, these stamp small pieces of gauze stamp gauze. So yes, we should do it transorally without a robot, but what the robot does is allows you to see the ICL, allows you to work with miniaturized vision is better, and which is primarily why and all you need to do now is to just stand on the face and that's it. So much more direct approach than what you had actually from outside. And just for this video again, this is touching on the coming from forward, it's a right-sided tumor. Fairly favorable from what we said in terms of radiological parameters. Incision lateral to the tonsillar anterior pillar. And when you do that, you have this parapharyngeal space coming right at you. This is an expanded parapharyngeal space. That's why it's so easily accessible. A normal parapharyngeal space may not be so easily available. But really, all you need to do is to get lateral to the tonsil, and the superior constrictor is the lateral border on tonsil adenoma in the parapharyngeal space. Again, pre-styloid, you see the styloid process there, and this is pre-styloid. You see the parotid is free. You see the vessels are pushed laterally, and again, an ideal situation for a transoral excision. So if you do these patients transorally and you do it with a Norbert, it's a fairly safe way of moving forward. I'll just show you a small clip. So this lady was much right inside right now. You can see it's here behind. So how do you approach it? You approach it straightforward operation. So you have the right hand I say there the tonsillar pillar, and it says just go down there, close the exit down, and then expand it also, and then they would down. So we published our experience a few years ago. It was published in the Journal of Robotic Surgery. Current experience is 6 cases. As you can see, we are benign nerve tumors, incision. And so when you apply this to the now that this has become available for you, you can use it for undertaking transoral dissections with parapharyngeal space schwannoma. So here's the general sizes. You can see you come laterally. You can see the ICL laterally pulsating there. Both pre-styloid. We use these stamp grafts, these stamp it doesn't take small pieces of blood loss is minimal of gauze stamp mean of 7 days. Complications, we have had a few, but in terms of NED status, they've all done well. Nobody's had a recurrence. So complications occurred in 2 patients. And you can see that these complications basically needed to tumor fragmentation to Horner syndrome, which is anticipated when you remove a benign nerve sheath tumor. Then whichever nerve is part of will generally end up having a problem. And a secondary hemorrhage once, which wasn't a major problem, which was quite problem, but every patient is disease free. Every patient has good mouth opening. Every patient does well. Though, for example, one patient had renal fragmentation no patient really allows you to work. I also present to you this most relevant literature that is available primarily basically with regard to a systematic review that came out a while ago with 44 parameters of human and approach and they found a very high rate of capsular fragmentation. This is why we become a little bit careful, especially with regard to pleomorphic adenomas. Schwannomas are firm, the bleeding is strong, that is a schwannoma. But pleomorphic adenomas are softer and they are ossificated and they only have a pseudocapsule. So you have to be very careful with pleomorphic adenoma. You shouldn't really be causing capsular fragmentation because if you
fairly
do that, you can
favorable
see
from what we said in terms of radiological parameters. Incision lateral to the tonsillar
lead to a recurrence late
anterior pillar.
Many years.
And when you do that,
you shouldn't be doing that.
you have this parapharyngeal space coming right
at selection. And as I said, I have already listed out what are the issues that you should be careful with in regard to case selection.
This is an expanded parapharyngeal space, that's why it's so easily accessible. A normal parapharyngeal space
it shouldn't be too close to the skull base.
But really, all you need to do is
to be
to
positioned
get
such that you can take a generous incision, get good exposure, and be able to do
to
that
the-
operation. So
get to
don't
the
do it
tonsil
if you sort of think
and,
that you can't do it well, if it's on the borderline. But
the
otherwise,
superior
it's a nice
constrictor
and good operation to
is
do,
the
and provided you're
lateral.
careful with case selection, provided you're careful, then this is a very good approach in addition to the other approaches that have already been set out by Dr. Rahman. So thank you.
Big adenoma in the parapharyngeal space again, pre-styloid. You see the styloid process there. And this is pre-styloid.
Thank you
You see
very
the
much,
parotid is
Dr.
free.
Takar,
You see the vessels
for
are pushed
sharing your
laterally.
expertise in oral
Plane and again an ideal situation for the transoral.
Very carefully at the
So if you do these patients transorally,
space tumor.
you do it with
once you have
Nobert.
seen the
It's a
ICL
fairly safe way of moving
come
forward.
out.
I'll just show you a small clip. So this fatigue was much
like this. Your presentation is very good insight for us. Okay, we will proceed to our last presentation from Dr. Nadia. Before we proceed to our discussion sessions, we will finish our presentation first. Our last speaker and our last topic for this session will be presented by Dr. Nadia Kusumawati. She's a plastic and reconstructive aesthetic surgeon and consultant of craniomaxillofacial surgery. Finishes her specialty from University of Indonesia and finishes her fellowship from Sekolah Special. And now she will give presentation
So
about
when you
facial
apply
nerve, animation. Okay, Dr. Nadia.
Thank you very much for the
introduction,
Doctor.
but now that this has become available for hand, you can use it for and take it transoral sections where parapharyngeal space like cervical schwannoma. Here's the
Other sizes, you can see
some laterally. You can see the ICL laterally pulsating there.
Both
We use these stamp graphs, these stamp. It doesn't take small pieces of blood loss is
Nice
minimal.
presentation.
Of course.
Like Dr. Takar.
Yes,
Okay.
but the host disabled the participant screen sharing. Maybe
Okay.
perhaps the same
Yeah.
reason as Dr. Takar.
I will ask.
Yes, it's done. You can share screen.
Of 7 days.
Okay.
Complications, we have had a few, but in terms of NED status, they've all done well. Nobody's had a recurrence. So complications occurred in 2 patients, and you can see that these complications basically needed to tumor fragmentation to Horner
already
syndrome, which
in
is
the
anticipated when you
screen,
remove a benign
doctor?
nerve sheath tumor. Then
Yes.
whichever
You
nerve
can
is
see,
part
but
of
not
will generally
have the
end up
slide.
having a problem.
Sorry.
And a secondary hemorrhage once, which wasn't a
I
major
already
problem,
screen
which was
shared
quite problem.
it.
But every patient
Yeah, but
In the
is
live-
disease free. Every patient has good
Yep,
mouth opening.
but
Every patient does
slide
well.
presentation is not here yet. You can stick your document, not your slide presentation.
I also present to you this
care the right side of the arm. You shouldn't really be causing capital fragmentation. If you fairly do that, you can favorable from what is said in terms of radiological parameters. The incision lateral to the tonsillar lead to a recurrence later anterior pillar. And when you do that, you should be doing that, and have this parapharyngeal space coming right at selection. And as I said, I have already listed out what are the issues that you should be careful with in regard to case selection. This is an expanded parapharyngeal space, that's why it's easily accessible. Normal parapharyngeal space, it shouldn't be too close to the skull base. But really all you need to do is to position, get the like generous incision, get good exposure, and be able to do the don't do it till you sort of can. You can't do it well if it's on the borderline, but otherwise period constrictor, good operation to do, and provided you're careful with case selection, then this is a very good approach in addition to the other approaches that have already been set out by Dr. Rahman. So thank you.
From top to bottom, we can see that the broke ptosis due to the paralysis of the frontal muscles, and it can lead to obstructed gaze, and also the paralytic eyelid, which can lead to exposure to keratopathy, and if not treated earlier, it can lead to corneal ulcerations and even blindness. And the paralysis of the lower facial muscle can especially affect the symmetry of the smile, pocketing of food
in oral
severe dental caries,
and again an ideal situation for the very carefully at the last. Do these patients transorally?
The etiology of the facial palsy can range from benign tumor, post-traumatic, and also inflammation like Bell's palsy, and even congenital.
Please say if you are moving forward, I'll just show you a small clip.
And this is only to show you that the acquired tumors lead to facial palsy, can lead to neuroma, sarcoma, acoustic neuroma besides the parotid tumors. And in order to manage the facial palsy, we have to seek goals in the more region side, with the forehead, oral commissure, smile function, and also eyelid. And before the surgeon and the patient can formulate the plan to we need to assess first the etiology, whether it be
from Dr.
whether there has to be a risk of pregnancy, and whether it has a
we will finish our presentation.
The duration of paralysis is very important. Resolve itself without intervention for 6 months or even 1 year. And we have to know the status
surgeon
of the other cranial nerve. Because sometimes other cranial nerves
University of Indonesia,
so we need to
and
know the
finishes
status
her fellowship.
This is all treatment modalities of facial palsy,
Presentation
whether it's surgical.
animation.
This is divided into the
Okay,
upper
Dr.
third,
Nadia.
middle third, and lower third region. In here, you can
very
see
much
the
for the
weakest
now that this has become available for that, you can use it as a take care of the directions where paralysis space like cervical schwannoma. Here's the sizes. You can see this on laterally. You can see the ICL laterally, 7 centimeters.
Tarsal strip canthoplasty, which I will explain later in the presentation. And the middle third and lower third can have two ways of reconstruction, whether be it static reconstruction and dynamic. The dynamic one is the true reanimation.
Then we use this to stamp graphs,
And this is the algorithm of the surgical management based on timing. We usually use an acute settings of a cutoff point of 3 weeks and below.
Pieces of blood loss is minimal.
Presentation.
Of course,
And due the nerve repair. And
Yes,
in the intermediate,
but the host disabled the participant screen share
until 1 year.
sharing. Maybe
Already have to use a neurotization procedure.
perhaps the same
And
with
also with
Dr.
chronic
Takar.
more than 1 year. It's
I will
usually
ask.
we usually
Yes, it's
think
done.
that the muscle here is already not viable for rehabilitation. So we have to replace the muscle with the muscle with a neurovascularized muscle. And we can do this by
of 7 days.
like the
Complications, we have had a few, but
And you can also
in
use
terms of
like
NAD
free
state,
muscle flaps or the microneurovascular techniques, like I would explain later.
they've all done
And
well
we
nowadays
cannot
at
forget about the
the
static
So
procedures
complications
that
occurred
help
in 2 patients,
editing or ancillary
and you
procedures
can
and
see that
can be
these
performed
complications
at
basically
any time
needed to
period
tumor
in the day.
fragmentation to Horner
already
syndrome, which
in
is
the
anticipated when you remove a benign nerve sheath tumor. Then
Yes,
whichever
you
nerve
can
is
see
part
the
of
not
will generally
yet
end
the
up
slide.
having a problem.
Sorry.
And the secondary hemorrhage ones, which wasn't a
I
major
already
problem,
screen
it's a
shared.
slight problem, but every patient
Yeah, but
In the
is disease-free, every patient has good mouth opening, every patient is
slide presentation is not.
Elderly patients, yes, I already clicked it when my computer is already my presentation series are and the options of medicine or how to
Just click the presentation you want to.
soft tissue rejuvenative techniques such as start with the introduction. My name is Nadia. Probably I'm a lower surgeon and I'm working and also facilitating.
be very
Can
careful,
you
right?
see
Why it's not going to be causing catheter fragmentation. If you fairly do that, you can be able to see what is said in terms of radiological parameters, where the incision lateral to the tonsil into a rectum
I already
anterior pillar. And when you do that, be doing that, you have this parapharyngeal
Facial lateral graft that we fold
space coming right at selection. And as I said, I have already listed out what are the issues that you should be careful with in regard to case selection. This is an extended parapharyngeal space, that's why it's usually accessible. Normal parapharyngeal space,
Thank you so
it
much
shouldn't be
for
too close to the skull base. But really, all you need to do is to position, get something like a generous incision, get good exposure, and be able to do the. Don't do it till you sort of can. You can't do it well if it's on the borderline. But otherwise, period constrictor, good operation is to be provided you are careful with case selection.
However, this is not true. This is just a static reconstruction.
Then this is a very
various
good
devastating
approach in addition to the other approaches that have already been set out by Dr. Rahman. So thank you. You can know my name again, parapharyngeal space again, please silent. This is the silent answer.
From top to bottom, we can see that the broke ptosis due to the paralysis of the frontal muscles, and it can lead to obstructed gaze, and also the here we can also see the dynamic which can lead to exposure to keratopathy, and if not treated earlier, it can lead to corneal ulcerations and even blindness. And the paralysis of the lower facial advanced technique of especially affect the symmetry of the
ECG vessels unfortunately
In oral
plain and again in ideal scenario to become very carefully at the these patients transformally
tumor.
we do it once you have seen the isolated
tumor, post-traumatic, and also inflammation like Bell's palsy and even congenital.
safety of this moving forward. I'll just show you a small clip of this material is much.
This is only to show you that the acquired tumors lead to facial palsy, can lead to neuroma, sarcoma, apophyseoma, the site of carotid tumors. And in order to manage this facial palsy, we have to seek goals in the more region side, with the forehead, smile. So that's why we, as a plastic surgeon, with advanced technical microsurgery, this functioning free muscle transplantation is becoming our first choice of many plastic surgeons. And many muscles have been reported as donor of this
presentation from Dr. We will finish our presentation.
For example, Zhou Chuang from Changchun, Taiwan, and also Dr. O'Brien in Melbourne, Australia, they prefer a two-stage with cross-facial nerve graft and free functional muscle transfer with gracilis. And also
surgeon
other cranial nerves.
University of Indonesia and finishes her fellowship. Animation.
This is divided into the
Okay, Dr. Nadia.
and lower third region.
Thank you very much for this.
compared to other muscles like pectorals minor or and the middle third and lower third can have two ways of construction, minimal, whether be it static reconstruction and dynamic. The dynamic one is the true reanimation. We host disabled neuron in place, and we cannot have that. Okay, this is the diagram of the two-stage facial reanimation using the gracilis. In the first stage, we use the healthy side in order to find the buccal branch of the facial nerve. And this is the algorithm of the surgical management based on timing. We usually use buccal branch settings of cut-off point of 3 weeks and below.
Blood loss is minimal.
And then we use the sural nerve, which is
Yes, but we host disabled the participant screen share.
one usually
Maybe
already have used a neurodegeneration
perhaps the same as Dr. Takar.
more than 1 year. Through the
I will ask.
we use
Yes, it's done.
that the muscle that is already provided. We have to place the muscle with the muscle with the buccal branch
Of 7 days.
and then
Complications, we have had a few, but in terms of NED state,
how do we find this
Like I would explain later.
just they've all done.
nerve to cut, nerve branch to cut? We use the nerve stimulator, which I will display later, and we exert some milliampere degree of current and to make it move, to make the patients move. And then you have to observe that the branch that you are nerve stimulating is producing the right kind of smile, because in lower branches you can have the grimace, more like this, and not movement to the upper and lateral. And then after banking successfully the cross-facial nerve graft, and we close it, and the patient is left to do the outpatient settings, and in 6 to 9 months, we do the second stage. The second stage is the free functional muscle from gracilis, where we harvest the gracilis muscle from the thigh, and we usually harvest almost all of the time.
So complications occurred in 2 patients, and you can see that these complications basically needed to tumor fragmentation to Horner syndrome, which is anticipated when you remove a benign nerve sheath tumor, and whichever nerve is part of generally ends up having a problem. And the secondary hemorrhage ones, it wasn't a major problem, but every patient is disease-free, every patient is good mouth open, every patient is
Slide presentation is
we have to be careful because this tip is needle, so we need to be very careful, longer in the stimulation in order to not injure the nerve dynamic branch. Our clinical experience is showing that they're mostly
very careful, right? Why you should really be causing catheter fragmentation. If you clearly do that, you can be able to see what is said in terms of pathological parameters. Your incision lateral to the tonsil into a rectus anterior pillar. And when you do that, once you're doing that, you have this parapharyngeal
that we follow
space coming right at selection. And as I said, I have already listed out what are the issues that you should be careful with in regard to case selection. This is an extended therapy.
Thank you so much.
It should be the skull base, like a generous incision, get good exposure and be able to provide period constrictor. Good operation is doing. Why did that careful with case selection? And this is a very good approach in addition to the other approaches that have already been set out by Dr. Rahman. So thank you.
From top to bottom, we can see that the broke toes due to the paralysis of the frontal muscle, and it can be obstructed gaze, and also the hearing respiration that use the blind more, and the paralysis of the lower facial advanced technique of microphone especially affect the symmetry of the
food
in oral
severe dental caries.
and again an item very carefully as it
Palsy can range from post-traumatic and also inflammation like Bell's palsy, even congenital. This is only to show you that the acquired tumors lead to facial palsy, can lead to neuroma, sarcoma, angioma, besides in order to produce and in order to manage the facial palsy, we have to go in the more region side, the forehead,
period of denervation is
so that's why we as a plastic surgeon with advanced technical microsurgery
picture from the second
this functioning-free muscle transportation is becoming our first choice of
we
many
use the
plastic
gracilis
surgeons.
nerve muscles
And
here
many muscles have
climbed under the microscope vascular supplies to the patient
even
presentation from Dr.
muscle is sufficient to coagulate coaxate the obturator nerve to the
it has
we will finish our presentation.
Here you can see that the distal ends of the nerve that bends downward has already
from Changchun, Taiwan, and also Dr. Brian in Melbourne, Australia. They prefer a two-stage with post-facial nerve graft and pre-functional muscle transfer with gracilis.
and then this is the video of the patient this is 7 months
Plastic surgeon University of Indonesia and finishes her fellowship. Animation.
This is divided into the
Okay, Dr. Nadia.
animation. Here you can very much for and the middle third and lower third can have two ways of construction, whether be it static construction and dynamic. The dynamic one is through reanimation. We use this
and this is not hematoma, and it will resolve later.
Okay, this is the diagram of the two-stage facial reanimation using the gracilis. In the first stage, we use the healthy side in order to find the buccal branch of the facial nerve, and this is the algorithm of the surgical management based on lining. We usually use buccal branch finding original cut kind of fluids and load. We use the neural nerve, which is because disabled the participant screen shift to 1 year, maybe already have to use a neural patient, perhaps the same as Dr. Takwa, more than 1 year. We have to place the stomach with muscle.
7 days. Complications we have had a few, but in terms of NAD state,
How do we find
like a rice
they've all done.
nerve to
protect the corneal from
nerve branch to
ulceration?
we use the nerve stimulator, which I will display
Non-surgical
later,
adjuvant treatment,
and we
including both
exert
stimulation
some
and
milliampere degree of
and there's also
current
controversy
to
surrounding
make it
facial reanimation
move, to
that
make the
I
patient
think we
move.
need
And then
to
you have
discuss.
to observe that the
First
branch that
being
you
the
are
timing of
stimulating
construction,
is
but
producing the
today
right kind
there
of
is more
smile,
defined
because in lower branches you
time.
don't
So
have the
when do
movement,
we do this?
more like
It's
this,
actually
and
very
not movement to the
variable
upper and
from
lateral.
other surgeons. So, but
And
it
that
is generally
after banking successfully the post-facial nerve graft, and we close it, and the patient is left to do the outpatient settings, and in 6 to 9 months we do the second stage.
whether you do it
The second stage is the free functional muscle from gracilis, where we harvest the gracilis muscle from the thigh, and we usually
surgeons also Dr.
harvest almost all of the
When this happens. So complications occurred in 2 patients, and you can see that these complications basically needed to tumor fragmentation to Horner syndrome, which is anticipated when you remove a benign nerve-sheath tumor. Whichever nerve is part of that generally ends up having a problem.
Sorry.
And the secondary hemorrhage one, it wasn't a
I already screen share
every patient, yeah, but it's disease-free. Every patient is good now. But slide presentation is not
so their absence during the first few months may suggest necrosis of the graft muscles. And how about the reanimation of the upper third phase? It is very challenging field. You need to reconstruct the very thin and small part of the eyelid. And the technique proposed is somewhat similar to the techniques proposing to reconstruct the smile, in which we need to do free functional muscle transfer, in which we need to do the platysma, because platysma muscle is very thin, is very pliable, and to reconstruct it into the upper eyelid area. But no other surgeons
and as I said, I have already listed out what are the issues that you should be careful with in regards.
Able to do this because it's very, very complicated and difficult procedure to do. And this is the proposed algorithm for comprehensive management of facial palsy. Like I said before, you have to use regions of the face to be your guidelines. Is the cornea adequately protected? Is no? Or is yes? If not, you can see the face, smile absent, or lower lip position. Is it impairing the oral incompetence? If yes, you have to reconstruct it region by region. And then you do physical therapy and contralateral chemodemonstration or Botox as a way to balance things out. And then semi-annual reassessment. That's basically it for my presentation today. Thank you for the attention, and any questions we give to the moderator.
Okay. Thank you very much, Dr. Nadia. It's very nice presentation. Well done. And give us another insight about how we manage the facial nerve palsy. So I think we can proceed to our second session for this symposium, is discussion session. Before, if the participant have a question, you can write it down at the chat box, or maybe you can also raise your hand, maybe, if it's possible for the committee. From the chat box, we can see that, yes, there's a question from Dr. Malinda. And this question is directed to Professor Alok Takar. It's a very nice presentation as always. She said, she's asking about what is your consideration to treat PPS tumor, whether by oral robotic surgery or open surgery. And do you also always perform FNAB for diagnostic deletions, or intraoral, or by some
Yes, I take the second question first. We always
This is a very devastating approach, in addition to the other approaches which have already been set out by Dr. Rahman. So thank you.
That may be an MR or we can do an MR.
Top to bottom, we can see that the growth is due to the paralysis of the frontal muscle, and it can be obstructed gaze, and also the airway.
Sometimes it may be done transoral too. If it is totally inaccessible, we may proceed without it, because generally radiology can also give you a very good idea of the diagnosis. But it's nice to do fine needle unless it's very, very impractical to do. So almost always We would not do an FNA if it's a carotid body, otherwise we'd always do. I also note there's another question. Sorry, the second question, what is your consideration to treat parapharyngeal tumor by TORS or open? So as I said, to treat by TORS, you need at least three things. One, it should not be terribly enhancing, so it shouldn't be a carotid body tumor. Two, it should not be a deep lobe parotid tumor, so you want to make sure that the tumor is away from the parotid. And three, the blood vessels should not be in the way of coming from in front. So the blood vessels should be laterally. So if the ICA is pushed laterally, if the tumor is not attached to the deep lobe parotid, and it's not terribly enhancing, then oral approach. If it's a deep lobe parotid tumor, if it's too far lateral, if it's too big, if the vessels are actually pushed medially rather than laterally, then we'll almost always do a transcervical excision. And sometimes for recurrent malignant tumors very close to the skull base, so you want even better exposure, you would do a transmandibular, wherein you would do a mandibulotomy and swing the mandible out and then do the operation.
Okay, thank you very much, Professor Alok Takar. And I think there's another question.
Microphone especially affect the symmetry of the brain.
When you have to combine.
So we haven't had to do that yet, but we do take consent from patients. It is possible that
also inflammation like even congenital. This is only
the setting that the tumor is too large to come out from the intraoral technique, then you may need to. So we take that consent, but if you're good with case selection in terms of assessing your radiology well, I don't think it's very frequent that you will need to convert.
Okay, thank you very much. And this is the question from me. During the TORS, where are you actually? Do you at the same room with the patient, or do you from remote room?
No, same room. So they made TORS. I was told that TORS was designed by the American military so that they could operate on patients.
To show you that prior to lead facial missions,
no, it hasn't worked that way.
Patient panorama, sarcoma, angiosarcoma, in order to manage this trend, in order to manage the facial costs, we have to go just in more regions, forehead, so that's why we as plastic surgeon with advanced technical microsurgery pictures from the patient free muscle transplantation is becoming again choice of many with the gracilis nerve muscles and like many muscles have has some Taiwan and also Brian in Melbourne, Australia, they prefer a very good size fish that fractional regeneration is treated with gracilis. And that
so no sir, if it's a tumor of the deep lobe of parotid, then it would probably be very close to the facial nerve just on its deep surface, and it would not be safe to come from the so that also it would probably be lateral to get access. So if it's a deep lobe parotid tumor, we would always do transcarotid approach by the facial nerve. If the facial nerve, for a transcarotid approach, it has to be free of the parotid, and the vessels have to be pushed laterally, and then when we do a transcarotid approach, it has to be free of the
and the middle third and lower third can have two ways to see it has minimal, whether be it static construction and dynamic. The dynamic one challenge through re-animation. Okay, and this is not it will resolve Okay, this is the diagram of the two-stage facial reanimation using the bracelets. In the first stage, we use the healthy side in order to find the buccal branch, smile, and facial nerve. And this is the algorithm of the surgical management based on timing. We usually use buccal branch heading or vaginal cut of the face and alone. We use the neural nerve from chest and also disabling participants can shift to 1 year area maybe already have used a notification perhaps the same as more than 1 year to do it. Step 1 after this is avoided with loss. If it comes back, if the muscle comes back after that, 7 days, how do we find like a rice nerve to protect corneal nerve branch? We use the nerve stimulator, which are some surgical and we exert some milliampere degree of and there's current controversy surrounding make it animation that I patient. And then you have to observe that the first branch that you are having a instruction is producing the right kind of small defined because in lower branches you have the when do we do it more it's actually very variable for an electro surgeon. So but and then after banking successfully post facial nerve graft and we close it and the patient is left to the outpatient settings and after 6 to 9 months we do the second whether we do it the second stage is the free functional also muscles from gracilis where we harvest the gracilis muscle from the thigh and we usually surgeons also harvest almost all of my
you can see that this complication basically needed to tumor fragmentation to anticipated when you move to the tumor. The secondary hemorrhage one, the positive every patient is free and patient
I think as Dr. Takar also said that we have to do the imaging study first and we have to see what's the suspected patient is it in the anterior part or in the breast line or the post line. In a case if we have performed a biopsy it's a fine needle aspiration not open biopsy. I think it's not need to do a open biopsy. You need only fine needle aspiration as we have our talk say that it's not better the fine needle aspiration biopsy especially in the first time that we have suspected vascular to
so their absence during the first few months may suggest necrosis of the
Thank you very much,
but I think Dr.
How about the reanimation of the upper third phase? It is very challenging. So you need
my experience in this tumor is very limited. I'm sorry.
Very thin and
maybe you have
small
an
part
opinion
of
about
the
the question.
eyelid. And the technique proposed is somewhat similar to the techniques proposing to construct a smile, in which we need to do free functional muscle transfer, in which we need to do the platysma, because platysma muscle is very thin, is very pliable, and to reconstruct it into the upper eyelid area. But no other surgeons
and as I said, I listed out the ratios that you can see.
this is very complicated and difficult procedure to do. This is the proposed algorithm for comprehensive management of facial palsy. Like I said before, you have to use regions of the face to be your guidelines. Is the cornea adequately protected?
And
is no?
we still have a question
yes.
for
If not, you can see this face, smile absent, actually position is in my comparing the nasal brain center. If yes, So you have Ministry of Health Hospital and then you do physical therapy and control chemomodification or Botox as a way to balance things out. And then semi-annual reassessment.
Great then.
That's basically it for my presentation today.
Okay.
Thank you for the attention.
Paralysis due to cancer cases. Does the histopathology of grading of cancer should be considered prior? Thank you very much, Dr. Nadia. It's very nice
yes, I think this
presentation.
Is the first and
well done.
Major questions you have to ask for
and give us another insight about how we manage
construction for the cancer itself as
facial nerve palsy.
Is there
so
possibility to have recurrence?
We can proceed to our second session for this symposium is discussion.
Those aspects
if the participant have a question, you can write it down at the chat box, or maybe you can also raise your hand, maybe, if it's possible, the committee. From the chat box, you can see that
in the near future, if
there's
it
a
comes
question
back, then
from
I don't
Dr.
think
Malinda.
Construction at all because like
And
I
this
said, this is
question
not
is
for
directed to Professor Alok
life-saving.
Takar.
This is not life-saving actually. This is reconstruction for improving your quality of
she's asking about what is your consideration to treat PPS tumor, whether by oral robotic surgery or open surgery, and do you also always perform FNAB? Okay, perfect. For diagnostic deletion, so or waiting intraoral or by for the imaging studies, what is the best
various devastating
which one
Top to bottom, we can see that the growth due to the paralysis of the frontal muscle, flexion and obstructed gaze, and also the
This may be done transoral too. If it is totally inaccessible, we may proceed without it, because generally radiology can also give you a very good idea. Except of course that it doesn't show the styloid process. But it's nice to do fine needle unless it's very impractical. Sometimes it also shows the styloid. Almost always. We would not do an FNA if it's a carotid body, otherwise we'd always do. But we often use a CT because it's cheaper. I also note there's another question. The second question, what is your consideration to treat parapharyngeal tumor by TORS or open? So as I said, to treat by TORS, you need at least three things. One, it should not be terribly enhancing, so it shouldn't be a carotid body tumor. Two, it should not be a deep lobe parotid tumor, so you want to make sure that the tumor is away from the parotid. And three, the blood vessels should not be in the way of coming from in front. So the blood vessels should be laterally. So if the ICA is pushed laterally, if the tumor is not attached to the deep lobe parotid, and it's not oral approach. If it's a deep lobe parotid tumor, if it's too far lateral, if it's too big, if the vessels are actually pushed medially rather than laterally, then we'll almost always do a transcervical excision. And sometimes for recurrent malignant tumors very close to the skull base, so you want even better exposure. So I think we did have some excellent presentations, wherein you would do a mandibulotomy and swing the mandible out and then do the operation. In quite detail. Of course, we didn't cover the carotid body tumor.
Thank you very much,
and that sometimes can
Professor
go unnoticed.
Alok Takar.
So, and I think there's another
especially affect the symmetry of the brain. Post-traumatic and also inflammation like seronatural, even congenital. This is only to make training windows.
Setting that the tumor is too large to come out from the intraoral technique, then you may need to. So we take that consent. But if you're good with case selection in terms of assessing the radiology well, I don't think it's very frequent that you will need to convert.
Okay, thank you very much. And this is the question for me. During the TORS, where are you actually? Do you at the same room with the patient, or do you from remote room?
No, same room. So they made TORS. Now, I was told that TORS was designed by the American military so that they could operate on patients.
To show you that prior to nursing need evacuation missions,
No, it
when
hasn't.
the patient has aroma, sarcoma, angiostoma, cytoplasm, in order to manage this one. And in order to manage the special pulse, we have actually to go just in one region, like forehead. So that's why when I have a plastic surgeon with advanced technical methods, pictures from this patient muscle transplantation is becoming again choice of may use the gracilis nerve muscles and making muscles that was already right in Melbourne, Australia. This for a very good science that proximal regeneration is special with gracilis. And that in the first stage, we use the healthy side in order to find the vocal branch, smile, and facial nerve. And this is the algorithm of a surgical management based on timing. We usually use the vocal branch original cut of the we use the nerve stimulator, which is non-surgical, and we exert some milliampere degree of current controversies to make it animation that the patient. And then you have to observe that the first branch that you are learning to play instruction is producing the right kind of modified, because in lower branches you have when do we do this order is actually very variable for an electro surgeon. So and that is after banking successfully post-facial nerve graft, and we close it, and the patient is left to the outpatient settings, and in 6 to 9 months we do the second. Whether you do it in the second stage, it's a free functional also muscle from gracilis, where we harvest the gracilis muscle from the thigh, and we usually surgeons also harvest almost all of
therapy with resection, radiation, or limited volume irradiation. Yes,
This may be done transoral too. If it is totally inaccessible, we may proceed without it, because generally radiology can also give you a very good idea of that. It doesn't show the styloid process, but it's nice to do fine needle unless it's very impact, and it also shows the styloid. Almost always, we would not do an FNA if it's a carotid body, otherwise we'd always do. But we often use a CT because it's cheaper. I also note there's another question. The second question, what is your consideration to treat parapharyngeal tumor by TORS or open? So as I said, to treat by TORS, you need at least three things. One, it should not be terribly enhancing, so it should be a carotid body tumor. Two, it should not be a deep lobe parotid tumor, so you want to make sure that the tumor is away from the parotid. And three, the blood vessels should not be in the way of coming from in front. So the blood vessels should be laterally. So if the ICA is pushed laterally, if the tumor is not attached to the deep lobe parotid, and
a new pillar of treatment for
oral approach. If it's a deep lobe parotid tumor, if it's too far lateral, if it's too big, if the vessels are actually pushed medially rather than lateral.
Overexpressed in head and neck squamous cell carcinoma and has the potential to be used as biomarker for clinical response to immune checkpoint inhibitor acting on PD-1 and PD-L1 axis. When PD-L1 expression analyzed were restricted to only tumor cell, there was no statistically significant increase in the probability of response. Conversely, when immune cells were included in the scoring system, a statistically significant increase in the probability of response was observed. So many immunotherapeutic agents are active against recurrent and metastatic head and neck squamous cell carcinoma, including nivolumab, pembrolizumab, durvalumab, and the upcoming atezolizumab. The predictive biomarkers can be applied to identify the benefit from PD-L1 or PD-1 blockade and its combination with chemotherapy, radiotherapy, or targeted therapy. Thank you very much for your kind attention.
Thank you, Dr. Gatot Sugiarto, for your very useful, very interesting information. There are several questions. For the first question for first speaker, Dr. Hamsu Katrian. You stated your presentation that there are several kind of biomarkers that state P53 MDM2, P14 cyclin D1, TGF beta, NFK beta, EGFR. Is that all has potential, same potential to become trigger to malignant, or one stronger than others? Yeah. And then the second, still for Dr. Hamsu, there's a role in liquid biopsy recently in diagnosis head and neck cancer. For saliva, the accuracy, the efficiency, and the simplicity, you can say that it's good, but it can be compared to other conventional biopsies such as nasopharyngeal biopsy or excisional biopsy on the neck by using only saliva or blood or serum. Thank you, Dr. Hamsu.
Thank you, Dr. Willy. Very nice question. Maybe I will answer the second question first.
Okay.
So the liquid biopsy is still on the progression for defining some disease, but an advanced research should be done, should be continuous to make sure that the specificity, the sensitivity of the biomarker from the liquid biopsy is good or not, because this is still in the early stage of the research. So I think it is too fast if we definitely use only the liquid biopsy for the make sure that this is one kind of a certain tumor. So now we we remain use the conventional biopsy to make sure what kind of the cancer. But in the future, I think there is an opportunity, there is a way to develop this liquid biopsy, because we have a technology, we have the research program to develop this kind of liquid biopsy. And for the first question, we have several many kind of biomarker. And we know that some biomarker may be indicate that this is for the increasing of the disease, or maybe the other one is for decreasing, or maybe to defend our body. So let's say maybe for the P53, this is for guardian of our cell, yeah.
Okay.
However, in cancer cell, the P53 is going to mutation. So maybe there is a possibility that P53 could also increase the cancer itself. So there are many factors that maybe we should what we call it explore anymore, yeah. And there are many function of the biomarker. I think that's all, Dr. Willy. Thank you very much.
Thank you. Very complete and interesting information, Dr. Hamsu. And then the second question for Professor Ahmad Farid. There are 5 steps of cell cycle: interphase, and then pre-mitosis, synthesis, and then G1, yeah, pre-synthesis, synthesis, and then pre-mitosis, mitosis, and then interphase. Which is the most effective way to killing the cell cycle, that kind of cell cycle, in order to make the cell cycle is stop to differentiate or to replicate? Professor Ahmad Farid. Is there Professor Ahmad Farid here?
Please unmute, Professor.
Professor, please unmute. Is still here, Professor Ahmad Farid?
Yeah, I'm sorry. I tried to unmute, but you controlling my voice. So
it's so clear. Now clear, yeah.
Okay, so basically there's no perfect way to kill cancer. As I told previously, we are facing with a very clever organism. We have a lot of chemotherapeutic drug that really targeted in each of the phase. For example, in mitosis phase, we have now docetaxel. So you can basically in that mitosis phase, the tubal agent will spreading and give the both cell to divide. At that phase, that taxotere will freeze the tubule and the cell will die. Or if you goes to the platinum base will go to the G1 phase that will interfere with the base, the single base pair, and destroy it. That's why you will see the NGMT gene, that even if we targeting those to blocking the base pair, the tumor itself, they have the mechanism. You give the cell with chemotherapy, right? They go inside the cell, and the clever cell with NGMT status, they will throw back the platinum outside their body. How clever is that? So sometimes you have to know more than just single pathway, or even you have to really know the characteristic of your patient type of malignancy. Most of the cells that we learn, they my suggestion, if you want to know, you have to learn the very difficult cell on your field. Like example, I learned about glioblastoma multiforme. That's the very difficult cell in the brain for the short survival rate, and how clever they have their own tools and they have their own mechanism. If you can learn the difficult cells, then you can apply it for the lower malignancy than that one, because basically if we have protocol in our field, right? So each protocol actually targeting the most common pathway that being agreed with most of the clinician, that they sensitive or resistant with chemo or radiotherapy. Like for example, now Dr. Gatot told us about the immunotherapy. That's very promising one, and I also check it in my cells, and that's tool, the immunotherapy. It's very personalized, because you have to check the immune status of your patient. That means you really can learn that from the consortium of the protocol, or you can check it by yourself in your patient. So my question is, in cell cycle, even if you see they seemsly like a similar, but it's not. So there's no perfect way. That's why we have to. There's no way you can treat your patient with monomodality, because we're facing the clever one. So you have to treat it with multimodality, same adjustment and several techniques.
Okay.
So one of them is cell cycle.
Okay, thank you. Fortunately, we can combine as a regimen. We call it a regimen.
That's right. That's right.
The regimen, several cycle of the chemotherapy.
That's right.
Can be
Even you can
and
add
kill
adjuvant. Now you can add adjuvant. This is not killing the cell, but just to weakening the cell before you give the real chemo cytotoxic agent.
Thank you. Very clear, Professor. And then the last question is for Dr. Gatot, internal medicine.
Sorry, Dr. Willy, the time is so limitation because we are going to next session.
Okay. Thank you. Thank you for all the speakers. I think this is very useful, very vulnerable information to us in order to knowing about the biological marker of the carcinogenesis. And hopefully, finally, we are all here to stay safe and healthy in this pandemic era.
Thank you.
Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you, Dr. Willy. Thank you, everyone.
Yeah.
Okay, we continue the next agenda, Dr. Farah.
Okay, well, maybe before taking photo for maybe a little seconds.
Okay. We have X slide, so we count.
No, I mean only the speakers and moderators.
Okay.
From Symposium 1 and from Symposium 2 maybe?
Yeah.
Yeah.
Please on the camera, everyone. Okay, we count to 3, Dr. Farah.
Okay.
1, 2, 3.
Yeah.
Okay.
Thank you so
everyone.
much.
Thank you.
Okay, so we will continue our next agenda. Thank you, Dr. Willy.
Thank you.
Very interesting discussion in Symposium. I think we not enough time to discuss and of course a lot of questions, right? Okay, we go ahead for panel discussion. Okay, the last session of the day is panel discussion. I want to invite Prof. Ibing Tan, MD, Dr. Ahmad Husnu Romdoni, SPTHT KLK VICS, Patologi Anatomi, Radiologi, Dr. Anggraini Dwi S, Dr. SPRK, Radiation Oncology as panelists to discuss recurrency nasopharyngeal carcinoma. And then, of course, we invite Dr. Ika Devi Mayangsari, SPTHT KLK. It will lead discussion. Dr. Mayang, are you ready? Okay, good. Before we start, Dr. Mayang, I would like to share the curriculum vitae of Dr. Mayang. Dr. Mayang is born in Jakarta, December 14, 1968, right? Education, specialist PhD in Indonesia University, and then IVHNOS, Global Online Fellowship Program, specific in oncology. And the last is observer, specific in cancer care, and SKCC from Pittsburgh. Of course, a lot of experience of symposium, seminar, and of course, a lot of publication. One of them, the last is about a survey of Indonesian otolaryngologist behavior in medical service during the COVID-19 pandemic. Okay, Dr. Maya, next time is yours, please. Still unmute, Dr. Maya. Okay.
The operator, please.
The operator can help, please, Dr. Maya, to mute the computer.
Okay, thank you. Yeah, thank you, Dr. Unram. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, professors, doctors, all panelists, and also all participants. Now we will proceed to the next session, which is this time is the time for panel discussion 1. It will discuss about the recurrent nasopharyngeal carcinoma, which is, I think this is a good topic because we know the recurrency rate for an EC is quite vary depending on the place that the case is found. Like according to Tao Su from China, the recurrency rate is about 15 to 80, 58%. But according to Perry from South America, the recurrency rate is about 8 to 10%. But another journal from I think South Asia, I think, it said that the recurrency rate is about 12 to 22%. So I think this session will be very interesting for us to hear and to discuss. Okay, so for this panel discussion, I will be accompanied with 5 panelists, with 5 experts. First one is Professor Ibing Tan, MD, PhD. Yes, maybe the panitia can highlight Prof. Bintan so everybody will know. Yeah. Prof. Bintan is a staff member of ENT Department of Maastricht University, Netherlands. He was trained as ORL-HN as specialist at the Free University Amsterdam and completed PhD in 1986. He is also appointed as visiting professor at Gadjah Mada University, Yogyakarta, and for publication, he has written over more than 100 papers. Okay. Prof. Ibing Tan, can you appear here? Okay. If it's difficult, so I will continue to our another expert, Dr. Ahmad Kusnu Romdoni, an otolaryngologist consultant. He's a consultant from Erlangga University. He's also finished the specialization training and PhD program from Erlangga University and currently has responsibility as a Vice Dean at Erlangga University. Dr. Romdoni was very active in publication as author, co-author, and also in a poster presentation. And next is Dr. Husni Changara, PhD, Specialist Pathology Anatomy DFM. He is a pathologist from Hasanuddin University, Makassar, and ever studied at Groningen University and Kobe University. Currently, he is working as a lecturer at Hasanuddin University. And the next from the radiology department is Dr. Anggraini Dwi, specialist radiology consultant. She is a radiologist from Erlangga University and finished the doctoral program also from Erlangga University. And next, Dr. Handoko, medical science specialist oncology radiology. He is working as a radiation oncologist at Faculty Medicine of University Indonesia Cipto Mangunkusumo General Hospital. And Dr. Handoko is also finished his medical doctor specialization and his Bachelor of Medical Science from University of Melbourne, Australia. So, my gratitude to all the panelists of...
Yeah.
Okay. How about Dr. Romdoni?
Okay. I think at the first, the patient came to the hospital before giving chemoradiation. It's stage 2, I think, yes. Is it correct?
Yeah. C2N2M0.
Yes. And if we just at the big city like Jakarta or maybe Surabaya, I think we can do the at least as to do the MRI or CT with contrast or something to diagnose with the radiology. But if we are in a rural area, I think for this situation, I prefer to do the biopsy from the thickening of the nasopharyngeal wall. This is my opinion. Thank you.
Yes, so Dr. Romdoni will do the biopsy first instead of the imaging.
Yeah, I agree, but it's depending on the possibilities you have. Because I was reluctant to do an immediately biopsy because that will spoil also the imaging. But Dr. Romdoni is completely right. If you are in a rural area, if you don't get an MRI or CT scan with contrast, then just take a biopsy because it's easiest way to get your diagnosis.
Okay. So if we have the tools, so which one is the most suitable one for the recurrency imaging? Maybe I will ask to Dr. Anggraini. Which one, Dr. Anggraini, should we do if there is the tools?
Yeah. Because the image is depend on the timing. So after radiation, soon after radiation, there will be edema, necrosis, something like that can obscure the tumor itself. So do the imaging after 12 weeks because the impact or the effects of the radiation decrease, and we can evaluate the recurrency or the not recurrency, the residual mass is clear after 12 weeks.
Okay. So, Dr. Anggraini?
Yeah. MRI is better than CT scan. And I think in some situation like submucosal tumor, it's very hard to do with biopsy. So in my opinion, first we do imaging, and then if all the equipment is available, I suggest imaging first and then we do the biopsy. Thank you.
So, Dr. Anggraini, which one is better, MRI or CT scan to evaluate the recurrency? Or if there's no CT scan or there's no MRI, like Dr. Romdoni said in some area, what is at least the imaging that we can perform?
If we do not have CT scan or MRI, it's very hard. So maybe a biopsy is okay. But if you only have CT scan, please do it. But sensitivity and the specificity for CT scan is lower than MRI. MRI is better because for soft tissue, I think best is MRI.
Okay, so if we have all the tools, so MRI is the best. But if we don't have MRI, so the CT scan is enough.
Yeah.
Right? Okay, how about you, Dr. Handoko?
Yeah, thank you, Dr. Mayang. I agree. MRI will be the imaging modality of choice, but if the patient can afford and the facility is available, maybe a full workup with PET CT can be of value to ensure that there's no metastatic disease.
Okay.
That's also a good option, but if it's available, but it's a good option because if the tumor is submucosal, then you will find it easier with the PET scan. But PET scan is not widely available in Indonesia, I think, yet.
Yeah.
Yeah, that's right. Okay, so this patient actually we have the MRI. There is complex collision with a distinct solid component at posterior central and central nasopharyngeal. So it was positive in MRI, but there's no enlargement of lymph node. So, and then we do the biopsy. The biopsy was positive. Dr. Romdoni, what should we do with the patient according to your experience?
Okay, thank you, Dr. Mayang. If we have a pathology from the biopsy said that non-keratinized squamous cell carcinoma nasopharynx, it is maybe it is type 2, yeah, type 2 of NPC, and the distance between the first radiotherapy and then until now is more than 1 or 2 years. Maybe I suggest to prepare for radiation, and if possible, we can do also the chemotherapy. And the chemo, I suggest as a concurrent chemo radiation.
What are you going to do to look for distant metastasis or regional disease? Are you doing ultrasound or is it? Because we have to know before we are going to treat this patient if there are distant metastases.
Yeah, I agree. Maybe we have this also the distant metastasis from this patient and restaging again for this patient. Okay.
Dr. Maya, sorry for interruption.
Yes.
We have something technical problem about the link, so maybe in 2 or 3 minutes we will out of the link, and we will share the link, the new link to all of the delegate, and we rejoin again. It's okay. Yeah, there's something trouble in the link. Okay, thank you.
In 2 minutes.
Yeah.
Do you share the link via WA or here from the chat room? The new link?
To leave now, the meeting.
we still have 2 minutes, Professor Bing.
Okay.
Kita harus pergi. We have to leave in 2 or 3 minutes. So, yeah. Next slide. Professor Bing wants to see the Eastern metastasis or do the restaging for this patient, and Romdoni had already got the treatment for this patient. Yeah. So for this patient, we get CT scan. PET CT. We get a PET CT. From the PET CT, the nasopharyngeal wall symmetric, no sign of recurrency, and there's no sign of metastasis, and also distant metastasis. Okay. So what next for this patient?
Yeah, it's difficult. You already had the positive biopsy, huh? It's for sure.
Yeah, we have the positive biopsy, but from the PET scan, there's no sign of tumor there.
Yeah.
And then, So which one we have to believe? The PET scan, the biopsy, the MRI, or the endoscopy? Because here we see the picture. The roof of the nasopharynx, there's a small lesion there. Okay, Dr. Romdoni, please.
In my opinion, the highest result we have to, our guidance is from pathology. So I think if the pathology said there is a tumor recurrency, I think we should prepare for the restaging and then we plan to the therapy for the new staging that we already suggest after we re-examine this patient. Thank you, Dr. Maya.
Okay, thank you, Dr. Romdoni. So we consider this is the recurrency cases without distant metastasis condition, right? So we treat like a recurrency. I would like to know about the histopathology from Dr. Husni Chagara. Is there any positive false result for the case like this, Dr. Husni? Dr. Husni? Dr. Husni Chagara?
Okay. Can you hear me?
Yes. We can hear you well.
Thank you very much. Yeah. So I just worry about the first information. Yeah, that this patient has already diagnosed for the first time is a nasopharyngeal carcinoma. But I think it's not enough yet. So many this diagnosis is not. I can get the more information because nasopharyngeal carcinoma, according to the histopathology aspect, we have 3 types. Yeah? First, keratinizing, and then non-keratinizing, and basaloid squamous. The first histopathology examination just point nasopharyngeal carcinoma, but there is no information it is what type the patient get in the first operation.
You mean from the 2017?
Yeah, yes.
From 2017, the histopathology is undifferentiated.
Okay.
Carcinoma.
undifferentiated. So include also non-keratinizing carcinoma, type of because they are two, undip and differentiated. So before I explain about the histopathology, basically when there is a patient come to our laboratory to get ask the pathology examination for I asked to the patient to go to the radiology to get imaging before biopsy or other examination in our laboratory. Yeah, but in case of there is no facility regarding to the radiology or imaging, of course we use biopsy as one alternative. From this patient, I think could be there is a recurrence. Maybe this the second diagnosis of this patient is non-keratinizing carcinoma. As we know, this type of nasopharyngeal carcinoma has correlated high correlated with the HPV infection. Compare the keratinizing squamous cell carcinoma. So probably maybe when the first not clearly, or maybe there is some recurrence in this patient. But
Okay. Is there any possibility of false positive or the biopsy?
Difficult, not clear the but
According your experience.
If biopsy is depend of the clinician when they take if they take the sample in good location and get we can diagnose as carcinoma. It is it is truly SCC, but usually we find negative pulse.
Okay, so if it is already positive, there's no chance it's negative.
But if we find the exact location and we see there's some island of the malignant area, of course we can decide that this sometimes if we can find the non-keratinizing carcinoma, we find only small spots. So we ask to the clinician, can I follow by immunohistochemistry by cytokeratin to find the small parts of the spot of carcinoma.
Okay, thank you, Dr. Hosni. Yes, Professor Bing.
Yeah, I agree with Homdon that if you have a positive biopsy, you cannot just say, well, my PET scan is negative, so maybe it's nothing wrong. But I should always be hesitant because you're going to go give a treatment, heavy treatment, and you have to be sure. So I should take a big biopsy around the visible tumor area and send it to the pathology again. And then if it's positive, then you have to treat the patient.
Okay, we'll do the rebiopsy then. Or enough for the previous one?
I should take a bigger biopsy because you can see the tumor in the nasopharynx. So I should take a bigger biopsy, send specimen to the pathology to have a clear answer, yes or no, and the infiltration.
Okay, but from this patient, because there is a discrepancy between the PET scan and MRI before, we did the second MRI with no signs of local and regional recurrences. So there is a discrepancy.
What was the time between the two MRIs?
Yeah, because there's a difference between the PET scan and the MRI. So we did the second MRI. And then from the second MRI, there's no signs of local, either the local or regional recurrences. So what should we do now?
What was the time interval between the two MRIs?
1 month.
April. Oh yeah, March, April. Sorry. Yeah, 1 month.
1 month. Okay, what should we do now, Professor Bing?
I should stay with my former request to do a bigger biopsy.
Bigger biopsy.
Yeah.
Dr. Ramdhani?
Because you have to treat this patient, maybe, or maybe not. You cannot say, okay, let's wait and see when you have a positive biopsy. You have to be sure what's going on in the nasopharynx.
Okay, Dr. Ramdhani?
Yeah, I think I agree with Professor Bing. Do the biopsy in bigger or maybe in multiple on the right and left, and to the place that we are suspicious about the recurrence of the tumor.
Okay, second one. How about Dr. Handoko?
Yeah, so I fully agree with Dr. Bing's statement. So there's a high suspicious of local recurrence, no metastasis. MRI sometimes can be very difficult to assess when after treatment. So I will add this case to discuss together with the radiologist and all the team, and if it's still inconclusive, yeah, I agree to do rebiopsy to confirm whether there's any recurrence or no.
Okay, so all three panelists agreed to do the rebiopsy. Okay, so we'll see what happened with the patient. We did the more bigger than biopsy. We did the biopsy with the nasopharyngectomy.
Okay.
But the results from the histopathology, normally it's already big. So, what's your comment, Professor Bing or Dr. Ramdhani or Dr. Handoko?
I think you did well because you did a local surgery, so no re-irradiation, so you didn't harm the patient that much, and you had to do something. You cannot say just wait and see if you have a positive biopsy. So I think this patient was treated excellent. It's only the question, was the tumor initially or not? But for the patient, it's a good outcome.
So, Dr. Ramdhani, what's your comment?
Yeah, I think it's very surprising because the first pathology said that it was non-keratinized WHO type 2, but after the nasopharyngectomy, there is no malignancy. In my opinion, maybe the small recurrence, the recurrence is in a small area of the nasopharynx. So when you did the nasopharyngectomy, so the part of the recurrence is already maybe spill out or something, and then I think, and then the rest of the tissue that you sent to the pathology, it said that there is no malignancy. I think it's because of the small area of the tumor in which there is a recurrence. I think, and then the procedure for nasopharyngectomy, I think it is a good idea, and I think I agree with the nasopharyngectomy. It is more less burden than the patient have to do the more radiation or chemotherapy for this patient. Thank you.
So, for this patient, is there any adjuvant therapy?
No.
For this patient? No?
just good follow-up. But it underlines indeed the importance to be sure of your pathology, because if you had done this after the first pathology, it was a little bit more surprised than now, because you did twice the biopsy, you could not do anything else than the surgery. So, but if you have a strange biopsy, just discuss it in the multidisciplinary team and do it again, repeat the biopsy, because that's the basis of your treatment. You have to be sure.
Okay, so we don't give any treatment for this patient again. For a case like this,
Dr. Mayang,
yeah?
if I may suggest, as we discussed this morning with Professor Christopher Go, he said that maybe we need to check like a EBV DNA or something in the blood of this patient. If we found the the EBV DNA is a high number, I think we should suspicious if there is a metastatic or metastatic for these cases. Thank you.
Okay, so I think that can be done for our follow-up, right? Professor Bing, I would like to know if we have the case like this, is there any place for PDT to give for this patient?
Yeah, initially maybe because it was a very superficial, apparently very superficial tumor. So if it also the second biopsy was positive, then you could have done this photodynamic therapy, and then most probably also you will not find tumor after in the follow-up. But I had it also in my presentation. Photodynamic therapy is effective, but the problem is that it's extremely difficult to implement this in Indonesia because of just practical reasons to get the drug registered and so on. But indeed, especially for nasopharyngeal cancer in Indonesia, it's a good therapy.
Okay, thank you. And how about you, Dr. Handoko? Is there any place for re-irradiation for this case?
So
if this is malignancy,
Okay, so I fully agree with the treatment of nasopharyngectomy. So we can see there are a lot of study already show that in recurrent head and neck cancer, including nasopharyngeal cancer, the first treatment option of recurrence locally or regionally is always resurgery, resect it. Only when we cannot resect it that we come to another modality. If in this case there's a positive malignancy after nasopharyngectomy, so there is a very high possibility that there's still residual tumor, then I will strongly recommend adjuvant treatment. After nasopharyngectomy, do re-radiation.
Okay, if the result is malignancy, yeah. But for this patient, there's no malignancy for this case. Okay, so I think we agree for this patient. We just now follow up the patient with close follow up, and maybe the suggestion from Dr. Romdoni can also good. We have to do the serology. EBV-DNA for the follow-up. Okay, so we will continue for the second case. Yeah, it's a male, 23 years old. In 2018, he came to the internist with a lump in the neck and was diagnosed with TB, lymphadenitis TB. And then was treated by the internist for 1 year for the TB. Okay, and then 2 years later, the lump was getting bigger, and then he went to the oncology surgeon, and then the oncology surgeon did the incisional biopsy at the left node, and it was found it was positive. So, Dr. Romani, what do you think about the incisional biopsy which is performed on this patient, and then how we can differentiate between the lymphadenopathy from the TB, because we know Indonesia is also endemic for the TB, from and differentiate it from the TB and the malignancy side.
Thank you, Dr. Mayang. Maybe I think is the most important thing is to check with the physical diagnostic for this patient. We know that the characterized of the lymph node swelling, but the TB is like a chain, so you can find it from the one to the other, and it is continue. Usually it is continue, and then if we see the lump or the tumor of the neck, because of some metastatic process, we can find the position or the location of the tumor is very specific. If we know that the location at the level 2 or 3, or maybe at the level 4 or 5, we can seek the origin of the tumor metastatic. But if we do if we find the tumor at the neck, I think the first thing that I suggest, we do the USG first, ultrasound examination, and then after you do the ultrasound, if you want to know further, you can do the NAB, or fine needle aspiration biopsy. This is my comment about this case at the first.
Okay, maybe Dr. Anggraini, how about to differentiate the neck node with the ultrasound?
Yeah, I agree with Dr. Andoni. Do the patient have already been a biopsy with ultrasound, or blind, or how about this patient?
This patient was done the biopsy, open biopsy, incisional biopsy on the left node. Yeah. And
no ultrasound, no imaging.
There's no data from the ultrasound.
Yeah, now we have a diagnostic tool like elastography with ultrasound. So first, before we make biopsy, do ultrasound first to evaluate whether this is infection or lymphadenitis or metastatic, because from the imaging we can differentiate. TB is specific because surrounding the lymph nodes, there is also there is infection surrounding the lymph nodes. So the lymph nodes conglomerate, and if we do the Doppler, the color Doppler, it will increase the vascularization surrounding the lymph nodes. It's very different with metastatic process, because metastatic process, the location of the process is in the edge of the lymph nodes. And from the elastography, we can also evaluate the elasticity of the lymph nodes. We can differentiate between the two process. Yeah, I make research on that and publish on some journals that we can differentiate between benign and malignant lymphadenopathy with elastography. So my suggestion, if we do the biopsy, please first do the ultrasound. Or if you you may be suspicious for head and neck cancer, please do the CT scan or MRI to make sure whether there is a tumor inside the head and neck with lymphadenopathy or not. Thank you.
Okay, so from the ultrasound, we can get enough data to differentiate between the process of the infection and the malignancy, right, Dr. Anggraini?
Yeah.
Yeah, okay. How about you, Dr. Handoko?
Yes, generally I agree. So there are a lot of differential diagnoses. A patient came with lump. It can be anything from infection to malignancy. It can be we should also think of maybe there is apart from head and neck nodal metastasis, there's also possibility is there possibility of lymphoma or any other differential diagnosis. So we need to have a proper complete examination of the patient, the history, and then we examine all the head and neck region, the characteristic of the node, and imaging. Yes, and the simplest one is ultrasound, but at the end, maybe the cytology, the fine needle biopsy, will be the one that will give us that will enable us to differentiate between whether this is infection or more likely to be a malignancy.
Instead of open biopsy for the neck, right?
Yeah.
Extremely important this case, because it should be a reflex. If you get the patient with a lump in the neck, the first should be always to do complete examination of the head and neck, and never jump into the node, but do aspiration cytology. That's what is in all protocols. Never do initially an incisional biopsy, just fine needle aspiration as first step.
Yeah, that's right. I think we all here agree that don't do anything to the node if we haven't evaluated all of the head and neck condition, right? Okay. So what happened with the patient? The patient.
Sorry.
Yes, Dr. Romdoni.
Yeah, I think on April 2020, there were some data that looking the situation according to more like lymphoma, because there is fever, loss of body weight, and night sweating. I think beside the TB, we also think about lymphoma, and I think what the oncology surgeon did with incisional biopsy at the left node, I think it is a right procedure, I think, in my opinion. Thank you.
But do you think we have to write to do the incisional biopsy before the FNA?
No, actually no. But if we we're sure that this is uh, more like a lymphoma, I think we can do the excisional biopsy.
Yeah.
But actually, it's much better if you do the FNAB first.
Yeah.
Thank you.
Yeah, I think
Dr. Maya?
Yes.
I may also suggest fine needle biopsy with ultrasound guided. So we do biopsy with ultrasound guided.
Yeah, it will increase the accuracy, right?
Yeah.
I think Dr. Husni also agree with this, right, Dr. Husni?
Usually maybe in all the hospital, if they perform fine needle aspiration biopsy before the incisional biopsy. But yeah, as you know, the fine needle biopsy has a little sensitivity. So yeah, if we find we can find the malignant cell in the fine needle aspiration is okay. You can say this is metastatic. But if we find no, there is no malignant epithelial cell in the aspiration. Yeah, it could be possibility there is some maybe because inflammation like a TB, or could be because of focus we perform FNA by blind, so maybe we cannot get the perfect spot that there is a metastatic focus. Maybe if I see this scenario in 2018, the glandular TB diagnosed as maybe because of from the fine needle aspiration biopsy. Yeah. We also have experience that in final aspiration biopsy, we cannot find a malignant cell, or there is some case that in TB, there is we call it epithelioid cell. Epithelioid cell is a macrophage, looks like an epithelial cell. But so this is a big make a bit difficult to distinguish between malignant epithelial cell and epithelioid that the characteristic of the TB. But if we find there is if we lucky, we find after we diagnose from finding, we suggest to the clinician to perform incisional biopsy, because by incisional biopsy we can distinguish exactly this is a TB, because there's some necrotizing necrotizing granuloma, and one is focus of epithelial cell in metastatic, this is especially in the nasopharyngeal carcinoma.
Okay, so for the pathologist, if the result is not sure yet, so they will ask for another step of the biopsy, right?
Yeah.
So okay, thank you.
I think we have to notice to the clinician the clinical aspect of the this is there is a inflammation sign in the around the tumor.
So back to the clinical appearance, I think. Yeah. Okay. So what happened with the patient? And then the patient went to the ENT surgeon, and there is from the evaluation of the nasopharynx, there is enlargement, small enlargement or small mass in the nasopharynx, and then the biopsy was done. The result is SCC, non-keratinized, and undifferent. Okay, so the MRI was done, and from the MRI, there is a mass at nasopharynx and enlargement of the neck at the level 2. So what should we do for this patient? Maybe Prof. Bintan?
Just do the usual workup. Again, look for distant metastasis, and then send it to the radiotherapist and the medical oncologist, because he needs clearly chemoradiation if it's a nasopharyngeal cancer. But I have a question: why didn't it take so long between April and July?
Yeah, because the patient just came to ENT on July before. He went to the oncology surgeon, which is, I think, they don't notice there's something wrong in the
That's also, you have to always to keep in mind, if it's 3 months, it's a pity, because it could have been possible to treat this patient in April.
There will be anything happen.
Yeah.
Okay, so you asked for the staging for this patient. We did a PET scan, no sign of distant metastasis.
Yeah.
This is the PET scan. Dr. Anggraini, you agree that there's no sign of distant metastasis for this patient?
Yeah,
only on
I don't see any on spine, also at the liver. We don't see any other from, we see on lymph nodes, in the cervical area. Yeah. But here from the second picture, there is also increment of the radiopharmaca here. It might be the bone at the spine, the thoracal spine. But I cannot see in the PET scan. But from PET and CT scan, we see uptake of radiopharmaca. Yeah, little but not so bright.
Yes.
Yeah.
Because it was stated that there's no sign of metastasis at that time.
Yeah. Okay. Thank you.
Okay. So the patient was diagnosed with NPC, T1, N3, and M0. what should we give for the treatment for this patient? Maybe Dr. Romdoni.
Thank you, Dr. Maya. If we see the patient like this, T1, N3, and N0, I think I will suggest to this patient to do the concurrent.
CAD loh sebentar loh. Mas Iri, ini yang dikirim dari Samsung Mas Iri. CAD sudah fix nih dok? Iya, insya Allah. Nah, bersama udah mulai. Udah, udah. Iya, iya. Asalkan. Yang terbaru deh, baru kan baru dong. Baru dihubungi dong. Bahkan jaminan jangan dari kita dulu, kan tidak boleh. Itu sebenarnya kita nggak ada dari kita dulu, itu menarik. Iya.
Already
This meeting is being recorded.
we knew that there is a residual tumor. Maybe before operation, we should do like a FNAB or something else to make sure again that's malignancy or no. Sometimes I'm thinking about the, like a tumor, and there is a stromal of the tumor, and if the cells, the malignant cells already killed by the chemoradiation, but the stromal still left behind. So maybe the stroma or the tissue or surrounding the tumor, which have give the imaging such as a residual tumor, maybe, but I'm not sure about that.
So if we are already in the middle of the surgery like this, and there is a history of
I think,
what should
we can remove the part of the residual. Yeah, we remove the part of the residual, but we have to remember that this is not a salvage surgery, so we have to left the structure which surrounding the vital organ.
Okay, so you choose, if we already in the middle of a surgery like this, you choose to just take out the big node and then done. Right? Yes, Dr. Ramdhani. Oh, okay.
Yeah, maybe Prof. Pintan
Prof.
idea. In case it is surprising.
Now, first, I should not have opened the neck initially, because first I should do the aspirin cytology, and if it was negative, then also you can watch the neck, because you never know after this chemoradiation, maybe it will be okay. But if you are in a situation that you have opened the neck and you have this tumor, and then I think you should take the lump out, but take care. What's also what Dr. Ramdhani said: don't hurt vital structures, because it will not make the difference if you cut the accessory nerve or the even important structures. Don't do it, because we have to think about the patient. And that's also the reason that I should not open the neck initially. I want to be sure if I open the neck, I have to get it out, radical. Otherwise, it's a waste of time and a waste of effort. And this patient will be worse than without surgery.
Okay, since this patient has a history of TB, so is there any possibility this is because the TB?
It's possible that he has also TB. Yeah. But then also, yeah, I should not open the neck, have opened the neck. That's the difference.
Okay. So, Prof. Ding and Dr. Ramdhani said should not open the neck, but we did open the neck. And what's the result for this patient? We did a level 1, 2, 3, 4, and the result. And this is the neck, the node. Yeah.
Yeah.
There's no sign of malignancy for this patient.
Okay.
Okay. So, what next?
Did he recover?
Keep recover. Follow up.
Okay. Just follow up.
Just follow up. And then we did the PET scan 4 months later with the appearance like this. New hypermetabolic everywhere, I think. Lymph node at precarina, right hilus, and also in multiple hypermetabolic lesion at bones, which is I think this is progressive disease like this. This is the picture of the PET scan before and after the surgery. And then if we see the appearance like this, so it is, I think it is difficult to define the frozen section during the surgery because it is because of the fibrotic or because it is the malignancy. So I think we can think from this appearance there is a progressive disease. If we don't take out the lymph node, maybe it will more aggressive. What do you think for this disease?
I think it's just a very aggressive tumor, and it already in N3, so that you can looking forward to get these surprises with this metastasis. And I think that it will not prevent the distant metastasis if you do the surgery in this case. And again, salvage surgery for lymph nodes, of course, that's the first step, first thought, but it must be possible to get it out radical.
Okay. Dr. Ramdhani? Dr. Ramdhani, I think you are still mute.
Yeah. So if we restaging of this patient, so we see that the patient with nasopharyngeal cancer with T0 and 0 but M1. So we suggest to do the some of the guidance show that we can suggest chemotherapy, adjuvant chemotherapy, and also we can use like a immunotherapy for this patient, such as anti-PD-1 or something else. Thank you, Dr. Mayang.
Yeah, Dr. Anggraini, I need your opinion for this case about this PET scan. Also, can we make sure
hello.
the next report that is...
Sorry, maybe my signal is not good.
You are good, Dr. Ramdhani. I
Can you hear me, Dr. Mayang?
Yes, sure. I can hear you.
Hello.
Yes. Dr. Ramdhani, I can hear you.
Dr. Mayang, can you hear me?
Yes, Dr. Ramdhani is okay. Your voice is good.
Okay, we can continue. Dr. Anggraini.
Yeah.
Can we make sure the neck is not a malignancy from the imaging? Is it?
Yeah, on July 7 is very clear that it is...
I'm sorry, my signal is not good.
Yes, Dr. Ramdhani.
Dr. Ramdhani, I think your signal is not good.
Yeah. But on...
sorry, Dr. Mayang, maybe my signal is so bad here.
Yeah. But we can hear you, Dr. Ramdhani.
Give any comment again?
Yes. Maybe we can hear from Dr. Anggraini first, Dr. Ramdhani. Yeah, Dr. Anggraini, please.
Yeah. On June 30, 2021, we don't see any uptake radiopharmaca at the left regional, but we see in the lung, at the anterior to the carina, and also at the bone, at the lumbar spine here, and also para-aortic and in the liver.
Yeah.
Yeah. So I think this is distant metastatic. This is metastatic.
Yeah. Yeah, I think I suggest to give chemotherapy, immunotherapy, Dr. Mayang.
Dr. Anggraini?
Yep. Yes, Dr. Mayang. Yeah, we cannot sure whether
This meeting is being recorded.
Dr. Mayang. Yeah, maybe Dr. Handoko have comment. Any comment, Dr. Handoko?
Yeah. This is quite common for nasopharyngeal cancer, especially anti-drusis, not properly managed earlier, resect doing the incision of biopsy. So this is what we expect. So what next we can do? So we have to discuss with the patient. In this case, the prognosis is not good. We can offer them palliative treatment and discuss with the patient whether they want to continue with adjuvant chemotherapy. But bear in mind that it's not going to eliminate the cancer. So just postpone progression of cancer. For the bone metastasis, if there's a symptom, if the patient develop pain, or if we want to prevent the fracture of the vertebral bone, then we can give palliative radiotherapy to the bone metastasis combined with biphosphonate.
Okay, sorry, there is a connection problem. Did I miss something here?
We have cured the patient in the meantime.
Thank you, Professor Lee, for the treatment motivation. They are already cured the patient. Okay. So the diagnosis of this patient. Okay. I think we already agree for this patient. We give the chemotherapy and also local radiation, right, Dr. Handoko?
Yeah, radiation to the bone metastasis, right?
Yeah. Okay. I think that's all for our discussion for this evening. I think there's one raised hand here, Dr. Vito. Do you want to ask something to the panelists? I think Dr. Vito cannot unmute. Maybe the panitia.
Good afternoon, all the panelists. Am I clear? My voice clear?
Yes. The voice.
Okay, I'm Vito, radiation oncology resident from Indonesia. I have a question for the panelists. It's a very nice cases. My question is there any relations between is the biopsy did previously, or maybe the neck dissections did after the chemoradiations could affect or could increase the prognosis of having recurrence or having metastasis in this case? Thank you.
Okay, a good question. Professor Bing, what is your opinion?
It's a very good question, because an old discussion, and in the old days we did, if you have an N3 and you treat these patients with chemoradiation or radiotherapy, then you do a salvage neck anyway. But that's in the past. And nowadays we are more reluctant to do this salvage surgery, and because also now we have the PET scan, and if the PET scan is negative, we wait and see, and we don't do the salvage. And in this patient, I think again the salvage is most probably very difficult, and there was not yet aspiration cytology. So I should have done first the aspiration cytology, and then most probably wait and see if it was negative. But if it's improved the prognosis, I'm not sure, because most of the time the N3 neck after chemoradiation is very difficult to do the salvage surgery. Radical. And if you are not radical, then I'm not sure you're doing good for the patient.
Okay, thank you, Prof. Bing. So radical, level 1, 2, 3, 4, and 5, right?
Now, radical, I mean that you have the tumor out completely.
Okay.
You don't leave a disease behind.
Okay. How about you, Dr. Romdoni? Dr. Ramdhani. I think connection as well. Okay.
I'm
so
sorry, Dr.
I
Maya,
think we.
I cannot hear anything from you.
Oh yeah. Oh, okay. Sorry, Dr. Ramdhani. So, what do you think about the fetus patient? Cannot hear. Okay. So I think we are at the end of this session. So I will ask to the panelists to give a short take-home message for the audience. Maybe starting from the senior one. Prof. Bintan.
Thank you that you had to think about this. No, we have discussed a lot of important things, but one of the things which is extremely important, if you have a patient with a lump in the neck, do first aspiration cytology and do it and repeat it again. And if it's not, if you don't get an answer, then maybe you can take it out, but don't touch the node before you have done aspiration cytology. I think that's one of the most important messages.
Okay. Thank you. Dr. Ramdhani, your take-home message for the audience.
Yeah, I think if we found the tumor in the neck, we have to careful because mostly the neck tumor on adult is a metastatic process, so we have to manage it carefully, and we have to avoid to do some procedure that can make the patient getting worse.
Yes.
So if you want to do the diagnosis, do the minimal invasive first.
Okay, like FNA.
Thank you.
Invasive. Okay, so Dr. Anggraini, you will give a short presentation?
I think time is so...
Okay, so take home message for us then.
Yeah, I think we nowadays there are many imaging modality to be done. We have ultrasound, we have CT scan, we have MRI, also PET scan or PET MRI. All the modality is to establish the diagnosis. So I think before we do the biopsy or we do the surgery, imaging modality can help you to make sure whether there is malignancy or not. I think it's, thank you.
Okay, thank you. And now Dr. Husni.
Yes, so to our clinician, yeah, if you have you find tumor in head and neck, please consider the clinical sign and symptom, and then please give us more information complete to the pathologist, because from the information we can consider is it benign or malignant tumor. And then yeah, the fine needle aspiration biopsy is the first line of pathology examination, but we have to consider the gold standard to diagnose of the tumor or is histopathology. We can find from biopsy or post-surgery specimen. I think it's enough.
Okay, thank you. And the last one is Dr. Handoko.
Yeah, thank you, Dr. Maya. So, as we are discussing a lot about recurrence, especially local and regional recurrence, so a big proportion of this patient can still be salvaged well. And whenever there's no distant metastasis, only local or regional recurrence, the first option is always surgery, no matter it's a nasopharyngeal primary or non-nasopharyngeal primary head and neck cancer. But because not all patients can be salvaged by surgery because of so many reasons, maybe patient is not fit enough for surgery or etc. We can consider other modality, radiation or radiation plus chemotherapy. Not all, if we look at the literature, if patients are able to be salvaged by surgery, then there's a 60% chance of surviving after 2 years. But if it is unable to be salvaged by surgery, we give chemo only or radiation only, or chemo radiation, then it dropped to 40%, or in some literature go down to 20% in 2 years the survival. But nowadays, with the advanced radiotherapy technique, we can give a more conformal, higher dose to limited structure. And if we can do proper patient selection, there are some selected patient population that can benefit a lot from advanced radiation, and we can obtain quite high overall survival and control rate with modern radiotherapy technique. That's all my comment. Thank you.
Okay. Thank you, Dr. Handoko. I think all of the message from the panelists is very clear. So if there's a lymph node enlargement of the neck node, so don't touch the node. Use the less aggressive modality with the imaging or the FNA, and then after the treatment, if there is a recurrency, so think about the salvage surgery. Okay, I think it's all for now. Thank you for your all comments and interesting discussion from the panelists.
Thank you for the nice cases.
It's very hard, right? May this program be beneficial for our daily clinics and patient. And I will give decision to the MC right now. Thank you for your attention.
Thank you.
Alhamdulillah.
Bye.
Thank you so much.
Bye-bye.
Our appreciation, a very great appreciation to all panelists, and also for Dr. Mayang for leading this very fruitful discussion this afternoon. So we have come to the end of the day one of the 6th ORL Head and Neck Oncology Conference. Thank you for the productive sessions, and we look forward to a more exciting discussion tomorrow. See you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you all.
Mau foto, Dok? What? Do you want to take a picture? Okay, so just turn on the camera, please.
The camera is on.
Turn on the camera, and the operator, be ready. So we have 5 pages. Okay, the first page. Could you please ready? The operator. Okay, let me try. Okay, page 1, 1, 2, 3. And then next, page 2, 1, 2, 3. Page 3, 1, 2, 3. And page 4, 1, 2, 3. The last page.
Okay.
1, 2, 3. Thank you so much.
Okay.
See you tomorrow.
Bye-bye.
Thank you so much,
Bye-bye.
Prof. Bye.
Bye. Bye-bye. Bye.
Thank you all. Ya, bye-bye. Assalamualaikum.
Bye.
Waalaikumsalam.
Thank you, Mbak Wayang. Thank you,
Thank
Prof.
you, Kak
Intan. Thank you, Dr. Handoko. See you next time.
See you tomorrow, Cak Don. Kita ke conference ya. Bentar, Bu. 5 menit.
Yang lain